Everyone, welcome to my channel. Today we are going to deal with salivary gland tumors, and in salivary glands I'll be covering mainly PA, mucoepidermoid, adenoid cystic carcinoma and Warthin's tumor. So today let us start with the first PYQ that has been frequently asked is the salivary gland neoplasms and in detail pleomorphic adenoma. So I'm going to start with pleomorphic adenoma, but before that we need to learn the classification of salivary glands. So we have major classification, that is benign and malignant, right? And in benign we have Warthin's tumor, we have pleomorphic adenoma, we have oncocytoma, we have your myoepithelioma, and in malignant we have mucoepidermoid carcinoma, carcinosarcoma, adenoid cystic carcinoma, basal cell carcinoma. Then we have something called as mesenchymal salivary gland tumors, and in that we have silolipoma, and then we have non-neoplastic, and in non-neoplastic we have silolithiasis, and we have silometaplasia, then we have siladenitis, all those things, right? So here is the detailed classification: pleomorphic adenoma, myoepithelioma, Warthin's tumor, oncocytoma, and in malignant we have adenoid cystic, basal cell carcinoma and carcinosarcoma. Then mesenchymal tumors are silolipoma. Then non-neoplastic we have silolithiasis and necrotizing silometaplasia. Okay, then coming to pleomorphic adenoma for 10 marks. What are pleomorphic adenoma? They are benign tumors consisting of cells exhibiting the ability to differentiate into epithelial, ductal and non-ductal components, right? So pleomorphic adenoma are benign type of a tumor which have the ability to differentiate into epithelial, that is the ductal component, which has the luminal component and the abluminal component. So basically ductal is the ductal component, which is the ductal cells which proliferate, and they are going to be present, this is the, and they are in the lumen, so they are also called as luminal cells. And the cells present outside the lumen are your abluminal cells. So in your abluminal cells you have your myoepithelial cells, and in your luminal cells you have your mucus cells, serous cells, okay, and ductal cells as well. So this is the epithelial component, which is ductal and non-ductal. Abluminal is non-ductal, right? Okay, so the pleomorphic adenoma are benign tumors consisting of cells. Pleomorphic adenoma are benign tumors consisting of cells having the ability to differentiate into ductal and non-ductal cells. They are mesenchymal like, okay, so they can be chondroid like, myxoid like and osseous. Now they are also known as mixed tumor, branchioma, enchondroma, enclavoma, endothelioma. So in the final exam they can also ask you what is a mixed tumor, what is a branchioma, what is a enchondroma, what is a enclavoma, what is a endothelioma. So if you define pleomorphic adenoma, it is not a true mixed tumor. It is, its morphological complexities is the result of appearance of a mixed tumor. That is, it is not a true mixed tumor, it's just giving an appearance of a mixed tumor, meaning the myoepithelial cells secrete matrix and they get embedded in that matrix, giving an appearance of different tissues, that is chondroid, myxoid, and osseous. PA accounts for 53% of parotid tumors, out of which 44 to 68% are submandibular and 33 to 43% are minor salivary gland tumors. Now, pleomorphic adenoma does not imply on cellular pleomorphism. That is your, again, like, it is not a true mixed tumor, right? It is rather its epithelial and mesenchymal components that arise from a single neoplastic epithelial lineage rather than multiple germ layers. Now, the name pleomorphic adenoma is given by Wills because of the unusual histological pattern of the lesion. Okay, now coming to the histogenesis, pleomorphic adenoma mostly arises from the first theory is the multicellular theory of how PA is derived. So the first theory is your multicellular theory, and the multicellular theory states that the pleomorphic adenoma arises from the intercalated duct of the reserve cells. Okay, so intercalated duct cells or the reserve cells from which it arises, these cells have the capacity of multidirectional differentiation. Both ductal and myoepithelial cells have this ability, and they produce abundant extracellular matrix. And there was one more theory, that is Dardrick's theory. He said that neoplastically altered epithelial cells with the potential for multidirectional differentiation might be histogenetically responsible for PA, right? So, neoplastically altered epithelial cells with the potential for multidirectional differentiation, right? Now, clinical features: 45 to 75% of all salivary gland tumors, gender is female predilected, age is 4th to 6th decade, right? Now, coming to the clinical features, it is 4th to 6th decade of life, 45 to 75% of all salivary gland tumors, female predilected, site is usually parotid gland, present in the lower pole of the superficial parotid. About 10% of the neoplasms arise from deeper portions of the gland. Approximately 8% of PA involves minor salivary glands. Now, minorly palate. So, majorly the PA occurs in the parotid gland, and it is usually the lower pole of the superficial lobe of PA. Right now, the clinical features is it is gender predilected is female. It occurs 45 to 75% of all cases. Site is parotid gland, 4th to 6th decade of life. Okay, and it is now in minorly it is present among 8% of the minor salivary glands. That is your palate. Most common is your palate, which is your 50%. Minor salivary glands arise from the palate, right? The upper lip 27%. The upper lip, this is your palate. Then your upper lip is 27 to 17%, rarely on the sublingual gland. Occasionally, these neoplasms grow in a medial direction between the ascending ramus of the mandible and the stylomandibular ligament in a dumbbell shape. Okay, so sometimes they grow in a dumbbell shaped tumor between the stylomandibular ligament and the ascending ramus of mandible. Okay, then coming to the clinic, appears as a mass on the lateral pharyngeal wall and soft palate in females frequently. Clinical presentation, it is small, painless, quiescent nodule with well delineated exophytic growth of affected gland, slowly increasing in size. Slow growing PA is less recurrent, and fast growing PA is having a greater chance of recurrence. Now, PA of parotid, no fixation to deeper tissues. It is not fixed to the deeper tissues. Usually irregular nodular lesion, and fixativity is in consistency, although the areas of cystic degeneration is noted. So, if in PA of parotid, it is not fixed to deeper tissues. It is nodularly irregular lesion, firm inconsistency, although cystic degeneration is seen. Sometimes may be palpated if they are superficially present. And no pain or but local discomfort is seen, rarely involves facial nerve. If it involves facial nerve, it can cause facial paralysis, initially mobile, but if it becomes larger, generally less mobile. Okay, on rare occasions, bilateral pleomorphic adenoma of parotid have been reported. Okay, now coming to the PA of the intraoral accessory. Size is not greater than 1 to 2 centimeter in size is not greater than 1 to 2 centimeter in diameter. It can cause difficulty in this is about we're talking about the internal accessory gland PA of parotid. Internal accessory gland PA. The major difficulty in the internal PA is that it can cause difficulty in mastication, talking, breathing. Palate is fixed to the underlying bone and it is non-invasive. Other sites are freely removable and easily palpable. Now, malignant transformation is rare of these minor salivary glands. Now, macroscopically, it is irregular ovoid mass with well-defined borders. In major glands, incomplete fibrous capsule and uncapsulated. So, in irregularly ovoid mass with well-defined borders, and in major glands, it is incomplete fibrous capsule and sometimes it is unencapsulated. Then minor glands are also unencapsulated but rubbery and resilient, and they have something called as the bossulated surface. Okay, then cut surface, that is we're talking about a LS or a longitudinal cut of the specimen. It is rubbery, fleshy, mucoid, blistering with homogeneous tan white color, and infraction may be noted. Microscopically, morphological diversities, that is characteristic features, are benign mixed tumors show marked histological diversity. Variation between individual tumors within the same tumor. Pleomorphic adenoma, being a mixed tumor, is composed of glandular, epithelial, mesenchymal like component. Okay, so it has the glandular component, epithelial component, and mesenchymal like component. So in histological features, we are mainly going to start with the characteristic feature. And benign mixed tumors show marked histological diversity. Variation between the individual tumors with same tumor. Pleomorphic adenoma, being a mixed tumor, composes glandular, epithelial, and mesenchymal like components. Now, PA classification is, it is principally myxoid and cellular, predominantly cellular, and extremely cellular. Okay, PA classification is, it is classified principally as myxoid and cellular, predominantly cellular, and extremely cellular. So the histological features is, it shows morphological diversities, that it is characteristic feature is it shows morphological diversity. It is benign mixed tumor and it shows variation between individual tumors. So if you compare parotid tumor with other type of tumors, it will not be similar. If you compare parotid pleomorphic adenoma with the same another parotid pleomorphic adenoma, those two also will not be similar. What I'm trying to say is, it is not similar to the same kind and it is not similar to the different kinds as well. And it has three variations, that is it has three mixed components, that is your glandular, epithelial, and mesenchymal. So the broad classification of PA is, it is myxoid, it is principally myxoid, and that is it is principally myxoid and cellular, predominantly cellular, and extremely cellular. So four main types is principally myxoid, myxoid and cellular, principally cellular, and extremely cellular. Okay, then coming to the epithelial components, it has two ductal and cystic component. So ducts are present and small cysts can also be seen which have the eosinophilic coagulum. So this is the diagram. So basically this is the chondroid area with chondrocytes like cells, and this is your mucinous area with your mucin which has been removed in the sectioning. Then you have your myoepithelial cells, you have your cystic areas, then you have your ductal component, you have your bone. Okay, so that is the histopath of the diagram. So it is like this, and it has a chondroid area, it has the ductal components, and it has your myoepithelial cells in the center. I'm just drawing a very rough diagram. Then it has the cystic degenerations, which has a eosinophilic coagulum, and then it has bone, right? It has bone and a cystic area. So this is the histopath of your pleomorphic adenoma, the ductal component and the cystic component. Epithelial cells occur as cellular nests, sheets of cells, anastomosing cords, and keratinizing squamous spindle cells. So cellular nests are present, sheets of cells, anastomosing cords, foci of keratinization. Then myoepithelial cells have a varied morphology. They are present as stellate, that is your angular type, spindle, plasma cell, and round. So there are these different morphological variants of your myoepithelial cells, that is, it is angular, right, and it is spindle, it is plasmacytoid, and round. Okay, so spindle, angular, plasmacytoid, and round. So plasmacytoid is rounded with eccentric nuclei and hyalinized eosinophilic cytoplasm, resembling a plasma cell in minor salivary glands. Now stromal changes. Stromal changes is it is produced by myoepithelial cells, an extreme accumulation of mucoid material between the tumor cell, resulting in myxomatous appearance. Okay, so the stromal change is produced by myoepithelial cells is extreme accumulation of mucoid material. So there is an extreme accumulation of the mucoid material between the tumor cells and giving a rise to a myxomatous appearance. Then vascular degeneration in these cells are seen, chondroid appearance is seen, foci of hyalinization, bone, and even fat can be seen in the connective tissue stroma. Treatment is surgical excision. For parotid tumors, it is superficial lobe parotidectomy and preservative and prevention of facial nerve. With preservation and prevention of facial nerve, local enucleation should be avoided because the centralized tumor may not be removed. Deep lobe total parotidectomy. Now the intraoral minor salivary gland tumors can be extrascapular excision. Conservative enucleation often leads to recurrence. Submandibular gland, removal of the gland, and hard palate excision with a little bit of periosteum and the overlying mucosa is also excised. In the other sites, enucleation. Contraindicated therapy is radiation. Radiation therapy does not affect on this, and prognosis is excellent with 95% recovery, and recurrence is the highest in myxoid type of tumor. Okay, it is 2 to 3% highest in the myxoid tumor. Factors, but otherwise prognosis is good. Prognosis is good. Factors are stellate nodules and pseudopodia and incompetence of capsule. Factors of recurrence is your stellate satellite nodules, which are these nodules present, and pseudopodia. Now malignant neoplasms are called carcinoma X pleomorphic adenoma. This is what I was looking for when I was telling you about malignant classification, that the malignant form of PA is carcinoma X pleomorphic adenoma, right? And the metastasizing benign mixed tumors occur in multiple sites, and the recurrence is high, obviously, because it is a malignant type. And the other type of malignant pleomorphic adenoma is called carcinosarcoma, okay, or adenolymphoma. Okay, mainly we will be dealing with this name, that is your carcinosarcoma, right? So that's all for PA. Then the next video we will be dealing with the Warthin's tumor. Actually, I'm trying to thinking about combining all the videos in one, like one chapter of salivary gland tumors, and we will be done with the salivary gland tumors. So let's see how much I can cover in this class. Okay, so mostly I'm going to start with Warthin's tumor in the next coming session. In this video only I will cover Warthin's tumor as well.